Welcome to Open Studio on Brattleboro Community Television. My name is Chris Lenois, and today joining me in the studio is Dr. Louis Josephson. He's the President and CEO of the Brattleboro Retreat. Thanks for joining me.
Thanks for having me.
It was just about a year ago
Yes.
to the taping date that we were in here and getting to know you. You were pretty much brand new at the retreat at the time, a couple of months even?
Yeah, I started at the end of January, so
Right.
It's just my year anniversary, and I appreciate the opportunity to come back in and chat a little bit about what's happened in the last year.
Yeah, well, it's been a busy year, as we were talking a little bit, and certainly when you go into a new work environment, you have certain expectations, and kind of want to just start in terms of, confirmation bias, I guess, if you will, right? What sort of things were you thinking about your experience at retreat was going to be that came true?
Well, the retreat, as I may have said last year, but I have more of a full appreciation for it today, is such an amazing historical place and has such a role in our community. I didn't fully appreciate, for example, that we are the largest employer in Windham County. We have over 950 staff. So it's kind of amazing to me that mental health and addiction services are the economic engine in some ways of our community. But besides that, we just have such a history here, and going back in time to our commitment to treating people with mental illness and addictions with dignity and respect. So that's just such a powerful thing. And it's in the DNA of the retreat. It's in our staff and their commitment in caring for patients. That part is just profound and really wonderful. I would say on the other side of things, there's a lot of things I think we needed to improve, frankly, and I've worked really hard this past year to kind of get us started down the road to what we like to call in our field of nonprofits continuous quality improvement. It's all about quality, it's all about patient care.
Yeah, well, and it's interesting that the next thing I was asking you about what you found surprising, but you kind of answered that as far as the radius
Yes.
of influence
Yes.
that the retreat has, and it dawns on me. I mean, you think about it as an industry in a way, and you have all these other support services. The retreat, given its history here, has probably drawn a lot of mental health providers and mental health services or supporting services to our area. Were there some that maybe we didn't have as strong a relationship with before as maybe you see and have identified?
Well, there has been a change over time in the sense that, back in the day, if I could say 20 plus years ago, mental health and how we paid for mental health services in this country was completely different. And so the retreat, even though it's sort of right here in our community in Brattleboro, was a little bit of an island, almost a town within a town. And we were paid decently. Now I look back in comparison, we were paid quite decently to what we're paid now. People of all sectors had robust insurance. They could come for a period of weeks for treatment services. And so we were more autonomous. We didn't need sort of community support. We didn't need state support. But over the last 20 years, and I think accelerated in the last 5 or 6 years, the retreat has become very much of a public hospital. If people don't know, we have the only inpatient psychiatric service beds for children and adolescents in the state. So we are effectively the state hospital for children and adolescents. After Hurricane Irene and the tropical storm that came through and destroyed the state hospital up in Waterbury, we have taken over a good chunk of state hospital patients. So we've gone from, I think, kind of a little bit of an island where private pay and insurance covered people's stays to now we are about 50% Medicaid, which means public support, taxpayer support, federal support, and really being integrated into the state system of care.
Yeah, your role as president and CEO kind of puts you over administrative as well as clinical.
Yes.
And something like the retreat.
Absolutely.
Let's start. I want to start with some of the administrative challenges because there are a couple of things that were happening while you were coming on board. The Centers for Medicaid and Medicare Services had just released the retreat from the Systems Improvement Agreement. State was investigating allegations of Medicaid fraud made by a former employee. And you said really early on that you were committed to making sure the retreat was never in that situation again. So let's talk about some of those changes you've made to ensure that.
Right. Well, the good news for me is in this first year that I've been there, and I know it's a short sample size, 12 months, we have had no problems with regulators or surveyors. And we've been surveyed with, typically a complaint will come in through the State Licensing and Protection Board. They'll come out for a couple of days, look through our records, talk to patients and staff. Every single time they've been out this year, it's been cleared with essentially no findings. So that's good news, and it gives us some breathing space to kind of shift the dialogue and the narrative for us at the retreat. And we're really putting in place, I think, things that will make us stronger and our patient care stronger. And my belief is you stay out of problems with regulators when you deliver great patient care. And so my biggest initiative this year with support of the board and staff has been to implement evidence-based practices in our inpatient services. And we've started that journey. We started it with one of our most challenging units, which was our adolescent inpatient unit, and we've seen a remarkable turnaround. So our goal in the next year really is to make sure every unit is using an evidence-based practice that addresses the symptoms of the patients we're serving there. And if we do a great job in that, the paperwork and all the issues that flow from that will really strengthen us at the retreat.
Yeah. On the Medicaid fraud allegations, the state was saying they were just wrapping up one of the last little bits of that investigation. Have they given you any indication when those will conclude?
No, and it's I think I can say publicly, I hope our attorneys will not be upset with me, I can say publicly that it's a bit frustrating. So now we're a year out. We're still waiting for the conclusion. I would say, frankly, if there's any concerns, they need to bring them to my attention, the retreat's attention, so we can remediate them. I have not heard of anything concrete, so we're optimistic in the next months, hopefully, they'll bring it to conclusion or bring something forward that we can take action on.
Okay. Let's talk about some of the patient care challenges, because back in May, there was a patient suicide shortly after that patient was discharged, within 24 hours, I believe. And at the time, I remember reading in the media that Retreat was already making some adjustments to its admission and discharge protocols. Wondering, when you look at things like that happen, and certainly anything that happens like that, if it's a time to also look at the culture. I mean, there's one thing you can do to put in protocols, but were there things that you saw culturally that might need to be changed?
Well, not culturally in the sense that I think the caring and the commitment to staff were there 100%. Are there things that we could put in place, and we have put in place this last year, to make sure we're dotting every I? Yes. So we've included this past year sort of what we call when somebody wants to discharge prematurely, a kind of against medical advice, which does happen. People will come in, they get admitted for a reason, they say, you think I need a couple more days here, I really want to go home now. We always have a psychiatrist, a medical doctor, review that patient before they're discharged, but we've implemented another sort of checklist to make sure we've looked at everything possible before we send somebody out against medical advice. And so we are tightening up our practices, but I think the commitment and the caring is there. The challenge for us, I think, as well as for any mental health provider, is I could be working with you this afternoon and evaluate you and say, you're not suicidal. You leave here this afternoon, go have a couple of drinks with buddies, have a difficult conversation with your partner, and things may look very different at 10 o'clock this evening. I'm not saying that as an excuse, but we only have a crystal ball that takes us so far. So within the power that we have and the time we have, we want to make sure we've checked everything off, but we can't always control everything that happens right outside of our doors even.
Right. We said it was a busy year, and I think it was like right a week before that happened, the Vermont Supreme Court issued a ruling in a case related to a former patient that expanded a mental health provider's duty to warn.
Correct.
Changing it from an identifiable victim to a foreseeable victim, and that subjected the retreat to a lawsuit from the family. Just for a little background for viewers out there, can you explain what's so concerning to the profession about this expansion of the rule?
Yeah, this is going to sound a little bit like inside baseball conversation, but it is really, I think, important for our community because it has affected how not just the retreat, but other medical and mental health providers respond to issues of dangerousness. So I've been in the field almost 30 years, and what I was schooled in day one until just before this decision was that if you have a patient that you're working with and they say, I'm really mad at my wife, or I'm really mad at my boss, and I'm going to leave here and I might hurt them, you have a duty to warn the identified victim, the wife, the boss. If you cannot reach them directly, you call the police. You do whatever you can in your professional capacity to protect those people. What this decision said was a bit different, was that mental health and medical providers, even if there's not a specific person, if we feel like the patient has a level of dangerousness, we need to kind of warn and educate people who might be in the path of this dangerousness. And that is a very broad way of talking about it, if you will. So what if we had a patient who we thought had a history of violence or had a potential for violence? Doesn't mean they're necessarily violent today. Didn't mean I'm going to go and get somebody today when I leave the retreat. This ruling would say, oh, well, they hang out at Dunkin' Donuts. Maybe I have to warn the folks at Dunkin' Donuts that this person, maybe not today, but in his history, could potentially be violent. Otherwise, we would be liable if he went and did something at Dunkin' Donuts and we didn't educate and warn the people at Dunkin' Donuts. We're very concerned because that's an incredible burden to put on the field. And we're also, frankly, worried about privacy concerns. We want patients to tell us, I'm having impulses, I can't control myself. If they tell us those things freely, we can work with them on them and help get it better. If people think, oh, if I tell Dr. Josephson that I'm having these feelings, I better not say anything, and then they might go out without help and do something. So we really want to make sure that we're protecting patients' privacy, that they'll continue to work with us in that private way, and also not set up a kind of a burden and an expectation that we can somehow miraculously warn the entire community about the potential dangerousness of a patient. I think that's almost like a false expectation that we have that ability or we could ever cover enough of the community when somebody's potentially violent.
Yeah, and we should point out that it was a 3-2 decision
Yes.
with a written dissent elaborating on a lot of things you just said. And I brought that up and I appreciate the context because right now Windham County Senator Jeanette White has sponsored a piece of legislation. It passed just the week before we were taping this. You're familiar with the legislation? Did you work with her in crafting it?
We haven't worked directly. Okay. We've tracked it pretty closely, and I think the goal is to kind of correct a little bit of the Supreme Court's decision to get our duty to warn back to where it was, and the public should really know that back to where it was is consistent with just every other state in this country.
Right.
So Vermont really was an outlier with this Supreme Court decision.
Right. It restores the original definition is what
Correct.
I've read about it, so you're comfortable with that as far as
Yes, and I think the public should really know that we do take dangerousness, both to self and others, really seriously, and we'll do everything in our power to protect families, community, et cetera, but we also don't have an expectation or the resources that we can miraculously, again, warn everybody about somebody's potential dangerousness.
Yeah. All right, let's look outward now
Sure.
into just mental health in the state, because you've also been very active in your first year in advocating for the mental health profession and reforming it. Conference last October you were the keynote speaker at, and you said Vermont lacks a mental health system, and your quote was, "I defy anyone here to tell me what our mental health system is and what it looks like." Great quote. Before we get to where Vermont is falling short, what is a mental health system? What should it look like?
Yeah, and I don't want to sound like I'm wordsmithing and trying to be silly about it, but really a system implies that there has been a thoughtful organization of services to meet the needs of a community. So we do have a healthcare system, I think. We've got inpatient care for people who are very sick. We've got primary care for people who aren't so sick. We have assisted living and nursing home level of care for people who need long-term care. And that's a system. Is it perfect? No. In mental health, though, I think we really got a patchwork of services that have come together over many years but don't really fit together as a system. And I think we see it every single day in this state with patients boarding, what we call boarding in medical emergency rooms with psychiatric problems, because there is not the ability for them to go to the right level of care in a system that is balanced, looks thoughtfully at what the needs of Vermonters are, and sets up the services to meet those needs.
Yeah, this gets to something else that you've talked about and had an op-ed about, which is about more almost outpatient kind of approach to mental health services. And that very much ties into something you were talking about as a bright spot in that same keynote address with integrating the physical and the mental health services there. I mean, it seems like especially with patient-centered medical homes, a lot more could be done to bring those things together.
Yeah, and that is a very positive national trend, is that we're seeing if we serve people with mental health and addiction issues within primary care at a lower level of care, you do save a lot of money and prevent inpatient psychiatric hospitalizations. So that's absolutely where we should be going as a state and as a country. That's not to say, and I've been pretty clear about this, mentioned assisted living. We need essentially assisted living for people with chronic mental illness in the state. We do not, and that includes children and adolescents. We need more options, because I can tell you right now, as we sit here today, we have people at the retreat who are there months and sometimes years longer than they need to be, just because there's not a bed or a service available for them in the community that will meet their needs. And that is a waste of taxpayer money, yours and mine, and it just doesn't make sense. And so for all those people who are stuck at the retreat. There's somebody in an emergency room today who could be well served in that bed at the retreat but can't get there because it's backed up.
Yeah, I think most of the conversation, right or wrong, has been around the cost of it and paying for it. And Governor Shumlin had proposed this all-payer model. Governor Scott now has taken over and has this pilot program for an accountable care organization for a select group of Medicaid patients that I don't think impacts anybody down in our area.
Not that I'm aware.
But as far as that approach to it, I mean, have you had a chance to study that and have any thoughts on this all-payer model approach, this accountable care model?
Yes, and I think as a concept, it has a lot of potential. So the idea is, as opposed to a medical hospital or psychiatric hospital getting paid for a day of care when somebody's inpatient, we would get paid a lump sum of money to care for a population of people. And if we can bring the cost, lower, we get to keep a little and give some back to government. If we go over that cost, it's on us and we have to eat that cost. So it seems to align the incentives more in terms of hospitals or caregivers who would order tests or surgeries or other expensive services that aren't necessary just to bill for them. And so it does make some sense. I think when you're talking about addiction and mental health, it's actually a kind of an interesting thing because we need more funding in an all-payer model or an all-accountable care model. Mm-hmm. It is precisely the patients that have a chronic health condition like diabetes or COPD and a coexisting mental health condition like depression or anxiety that can benefit from more services. And if we do better with addictions and mental health for those chronic conditions, both mental health and regular health, we bring down the cost of care. It's the patients with untreated mental illness who have a chronic medical condition that costs 40% more than your average patient with diabetes. So there's a real opportunity for us, but it's going to mean some investment in mental health and addiction care.
Yeah, of course, Governor Scott isn't the only administrative change that has happened since you gave that keynote address in October. We also have had a change on the federal level with a new president and a lot of rumblings about changes to health insurance and health care. And I don't know, question marks as far as have you got any concretes as to the direction of things are going to go and how it's going to impact a state like Vermont and an institution like the Retreat?
That's the multi-million-dollar question.
Right?
I know the Vermont Hospital Association has really been struggling to read the tea leaves out of Washington, and I'm sure the Scott administration has as well. I wish I could be more specific. Right before I came here today, President Trump was on the wires saying, who knew that healthcare was so complicated? So I did.
Yeah.
And I bet most of you are listening audience
about that, right?
So we're hopeful that they'll come up with something sensible is all I could say.
Well, we have, and I'm sure you've had a chance to speak to our Washington, D.C. delegation, Congressman Welch, Senators Leahy and Sanders. They understand this. They get it. Have you been able to have good conversations with them about it?
Absolutely. And, I think for us, what we all line up about health and mental health is access to care. And that means you need some level of benefit, whether it's through Medicaid or another kind of insurance provider. When you have uninsured people who aren't getting the care they need, that's when we're paying a lot more out of pocket.
Yeah. Now, Al Gobay, elevated from Green Mountain Care Board into a role of the Secretary of Agency of Human Services. It was just at the beginning of February, he talked about a deep dive into the mental health system, or maybe lack thereof. Is that something that you've been involved in?
Actually, I have been. About a week ago, I was invited up to Waterbury with a bunch of other folks in the mental health field to talk about how we're going to fix the mental health situation. There's been some testimony up in Montpelier at legislative committees about what's happening with mental health. I think people are very aware of people with psychiatric issues waiting in emergency rooms way too long. And so I give Secretary Gobay a lot of credit. He's wanting us to unpack what's happening, why patients are stuck in the system. And I'm actually going to be co-chairing one of the committees that came out of that meeting. So stay tuned. We're going to be coming up with some recommendations. It's always the question, how do you make things work when there's no money?
Yeah. Which committee?
It's a committee really looking at the community system of care and why patients are, can't access services. And, frankly, what I'm going to tell the commissioner, I told him this at the meeting the other week, is if we have a limited amount of money, we've got to prioritize the population we're serving. And frankly, it's people with a chronic mental illness in the state are not being well served enough. And it's okay to say they're our priority. We're going to make sure we have enough for them and unburden the emergency departments.
Right. Well, I mean, you're coming from outside and lending this outsider perspective to it coming from California
Right.
most recently. I know you've had other stops along the way as well.
Absolutely.
But I mean, is it a situation where other people are bringing external ideas and are you hearing them all align? Is everybody kind of seeing the same challenges and the same pathway at this point, or
I think it's too early to say. The problem often is political will. So what I'm talking about in our mental health system is essentially triage, right? We probably have 50 bridges in the state of Vermont that need work. We can't pay to fix them all this year, and so the Department of Transportation is going to endorse the top 3 that need to be fixed. And I'm saying really it's the same with mental health care. We'd love to do everything possible for our population here in Vermont. If we don't have the money, we've got to take care of the neediest patients first and see what we have left over. Problem with that is when somebody calls up and says, what about the program for my son? It's not available like it used to be. And one of the things I appreciate about Vermont now is just what a small personal state we are. And one mom or dad who's up in Montpelier saying you can't cut that really can change the whole policy direction of the state. I'm not saying that's a good or bad thing. It's just the way it is sometimes.
Well, I would think with what you're advocating for, the community-based approach, another aspect of this is probably still having people overcome that stigma about mental health, the fear that's instilled in people, and you need to sequester this population of people while they get treatment, and all of a sudden they come out and they're well, and there's like this invisible wall there. I mean, how much of this is money, and how much of this is still that sort of perception, that sort of work you need to do to change the perception?
Well, I think it's both, and I'm glad you brought up stigma. It's such an important part. We've got effective mental health treatments for the most common mental health conditions, and people should access services. We do have a parity law in this state which says you should be able to get mental health services the same as if you were getting physical health services. So we ask people to not suffer in silence and get services. So we're very excited about pushing the anti-stigma agenda. So it's partially stigma, it's partially how we fund and set ourselves up for success or failure in the state as well.
But that's not really something you can throw dollars at and make it go away. I mean, this is a mindset sort of thing.
It is, but you can also, with the parity law, you can enforce the parity law. And I would say not just in Vermont, the enforcement of parity law across the country is spotty. So I encourage people, if they feel like they're not getting what they're entitled to on the mental health side, to speak up to Medicaid or their insurance provider and say, I'm entitled to this service.
Yeah. You brought up referencing the adolescent unit for mental health and substance abuse treatment earlier, Tyler 3.
Correct.
It was what it's called, and a story about that recently in the paper about these new approaches, these new clinical approaches. Acceptance and commitment therapy, or
Correct.
ACT, and dialectical behavior therapy. We again don't want to get too in the weeds, but I thought just the snapshot I read in the article was really interesting, and wanted you to elaborate on it a little bit.
Yeah, so we are using this dialectical behavioral therapy. It's an evidence-based therapy on Tyler 3. And staff and the leadership chose it because it's so good at helping patients who have severe emotional dysregulation. And your audience might say, hey, my teenager every day of the week has severe emotional dysregulation. That's why we think DBT is going to be effective. So we've got a window of time. People might be with us for a week or 10 days to try to build their skills to keep their emotions and their behavior regulated within a more of a normal range. So DBT gives staff the tools to work with kids. And I think the real difference now on Tyler 3 is if you go up there at 9 in the morning, besides school time that the kids need, obviously, they're going to be in DBT-style groups the whole day through after dinner. So it's promoting things like mindfulness and emotional distress tolerance, we call it. So when that kid in the classroom pokes you or mom says something that aggravates you, you don't fly off the handle in the same way. So we're very excited about that, and also the ACT therapy is going to be something that we've seen as being very effective with both a mental health condition and an addictions condition, and in our adult population it's very common to have both, so that's why we picked the ACT model.
Yeah, right, well they both seem, in reading about them, seem to feed into this community-based approach in terms of giving the patients more skills, more of an understanding when they aren't inside the retreat
Absolutely.
what they'd be dealing with.
Yeah, I mean, the people who are with us should, we have some outliers where patients for different reasons may stay for a longer period of time, but mostly we have brief stays at the retreat. And so we want to give people the tools to be effective at home and school and work, and hopefully keep them out of the hospital. That's our main goal, is to reduce readmissions to the hospital.
Yeah. Is that something, I know that for physical health, like Brattleboro Memorial Hospital is measured on those sorts of things from Centers for Medicare and Medicaid Services, discharge and revisits, same things apply to you all?
Same story for us. And actually, I just had a call last week with the Dartmouth Psychiatric Research Center, a group I had worked with when I was in New Hampshire, and we're going to look to do a new program with them where they have a kind of a tablet that is loaded with questions. If you were admitted with depression, let's say, we load a series of questions in the tablet, and every day for 30 days, when you leave the hospital, we'll give you a tablet. For 30 days, you log in and answer questions on depression and whether you've used the coping skills and strategies we've given you at the retreat, whether you filled your prescription, whether you have a side effect you want to ask somebody about, and we're going to give that for patients 30 days post-discharge to see if it helps reduce their readmission rates. So we're pretty excited.
Let's talk a little bit about priorities for the next 12 months.
Yes.
We'll set a date to have this conversation again, right?
Okay.
but I mean, obviously you've made a lot of great strides and accomplished things, I'm sure. Is it more of just kind of building on that success? Do you see other directions that you need to go? Or obviously a lot of it also plays into what happens on a country level and a state level, but.
Yeah, great question. Well, it really lines up with our strategic planning process, which is ending the end of March, so just another month, and we'll have a formal strategic plan that we'll be able to tell the whole community about. And our priorities, I could tell you right out of that plan, are improving our financial situation. We are not like other hospitals where we have lines of business that make money like lab and oncology and cardiac care. So we really have to be good stewards of the resources we have. So getting our financial sort of foundation in order is a top priority, along with the clinical excellence and being able to demonstrate it and measure it and drive it through the whole organization. So those are things, and really looking at new opportunities, whether it's with a Dartmouth, whether it's with another provider, trying to partner, I think, better with the state of Vermont. I think people don't know statewide, certainly. I think maybe in Windham County people know more about us, but as a new person to the state, I will tell you there's a little bit of geographic bias for where we are. People, policymakers and people in human services will say, oh, you're so far away down there. But we really are a resource for the whole state, and trying to educate and partner with the state to make sure they take advantage of what we have to offer, maybe some good opportunities for us as well.
Yeah, well, so far away in Vermont is such a relative term,
Correct.
right? It seems to be, at least. When you think about some of those priorities and how they also overlap with this deep dive on the state level, I mean, how quickly can you move forward with some of these things? I guess, or maybe what the timeline is for what Algo Bay wants to accomplish with the work that you're all doing in terms of looking at establishing more of a coherent system.
Yes, and I think that's a great question. It really does line up. It's kind of exciting. One of the things about the retreat is, since we've been here so long and we're such a part of this community, that we can stand up a new program here on our campus or nearby, and we really don't experience the not in my backyard phenomenon that other communities might have. So we can be more responsive. And I'll give you another example of something that would make a huge difference right away. Is we're starting a new telepsychiatry program, so that when we've got patients at the retreat or Brattleboro Memorial has a patient in their emergency room, we'll be able to beam in a psychiatrist to interview and assess that patient, maybe start them on some medication. That's the type of approach we really need to take statewide, because we need to spread those resources. And in particular, the research shows, for example, if you had 10 people waiting in emergency departments with psychiatric issues today, if we started them on medication today, 25% of those people would be able to be discharged without being hospitalized. But you got to have that psychiatric resource available, and that's a big one of our strategic goals this year, is to stand up telepsychiatry.
Yeah, the more rural the area, the more critical technology becomes. It's kind of ironic that it sort of like moves diametrically, but that really is the solution for a lot of these things.
It really helps.
Yeah. Dr. Josephson, nice to talk to you again this year.
Pleasure.
I hope it's not 12 months again. Hopefully I'll see you out in the community, but thanks for your time today.
Yeah, it's great. Thanks for having me.
All right. And thank you for watching this edition of Open Studio on Brattleboro Community Television. We want to remind you to go to the website brattleboro.tv.org to watch it on demand, as well as to see other editions of this program. Thank you.